Good evening, everybody. Welcome to this meeting of the Adults and Health Scrutiny Board. Thank you for coming, everyone. Just to remind everyone to please do speak through the microphone, otherwise we can't hear you, and more importantly, if anybody is watching online, they can't hear us. And also, when you finish speaking at any point, could you please remember to turn your microphone off? Thank you. So first of all, I do have some apologies for this evening. I have Councillor Froggatt, Councillor Pegg, Andy Smith and Pervez Sadiq. Any other apologies? No? Okay, thank you very much. I do have a late item as such. It's not really an item, but just to say to the board members who are here this evening that for items 5, 6 and 7, I am going to hand over the chair to Councillor Lonsdale. So are members happy with that? Yeah, thank you very much. So that's what I'll do in a moment. Thank you. Any declarations of interest? No, thank you. And the minutes of the meeting on the 1st of February, are we all happy to accept those minutes? Okay, thank you very much. So now I'm going to hand over to the Vice Chair, Councillor Lonsdale, who's going to lead on the 3 content items this evening. Thank you.
So, thank you very much for accepting me to chair these items. So, the first item is for mental health post-COVID response. I believe we have a presentation on that. Would you like to do that, please?
Thank you. My name's Gareth Harry. I'm one of the exec directors of Derbyshire Healthcare Foundation Trust. We're the main mental health and learning disability services provider in the county, in the city. We also provide children's services in the city as well. The slides that I've pulled together for the presentation tonight were actually based on a briefing note that was developed at the height of the Omicron wave in the second week in January. I think they've been circulated ahead of the meeting, but I'm going to talk through them because they give a really good snapshot of where we were in terms of our response to the Omicron wave and what it meant for our services and the decisions we were having to make at the time and the pressures that services were under, but also I'll be able to provide a little bit of context and background to how things have moved on since then, although services are now, we are getting impacted now as we speak around the latest increase in cases. So if you can have the next slide, please. Thank you. So the wave of the Omicron wave that came through, obviously we've had previous waves of the pandemic. I've been here before, I think it was last summer, and talked through the impact of the first 2 waves of the pandemic and the impact on mental health services. I'm mainly going to focus on the last 3 months. The wave that we had for the Omicron wave in December through to the end of January, when it was at its peak, probably in the second week in January, had less of an impact in terms of acute services, in terms of patients being admitted, and I mean by that the large acute hospitals, than it did in terms of the impact it had on general community transmission and therefore the number of staff both in our organisation but also in adult care and the voluntary sector who were having to be off work, ill or isolating. So that was the major impact of the wave that we had at the end of December and into January. We did have some positive cases on our wards. So at the height, we had 24 patients in Derbyshire Healthcare acute mental health beds, 24 in total, so that included our older adults beds. 18 were on the acute mental health wards. So I think we had 4 wards that were declared in outbreak, but when you had positive cases on the wards, you weren't able to admit onto those wards within the mental health environment because we've got dormitory facilities, mainly in the acute wards. So it definitely had an impact on, when we had positive cases, on the ability to admit during those times, but we didn't have a large number of people who were outside of Derbyshire. I'll come on to that in a moment. The main impact was, as I've said previously, on our workforce absences. We had, in the week straight after New Year, we had 134 people off ill. That was down from the previous week, which was at its peak, was 167. That's just people ill with COVID. If we think we've got a normal sickness absence level of about 5%, 4-5%, this put that up to 12%. So it doubled our people who were ill that were off work. But also there was an increased number of people who weren't able to come into a workplace and had to work from home because they were either isolating or they were caring for family members. So it isn't just your sickness absence numbers, it's the wider impact of people being unable to be in their normal workplace. As I said before, we had 3 people who were at this time, at the peak of the pandemic, in out-of-area placements. So people who were inappropriately placed outside of Derbyshire for acute mental health beds. We do have a unit in Castle Donington, but that is specifically commissioned at Mill Lodge Hospital. Although that is outside of Derbyshire, we have got arrangements in place to ensure continuity of care with that particular hospital. So they're not considered to be inappropriately out of area because the internet links, the electronic patient record links are the same as if they were one of our beds in Derbyshire. So throughout the height of this, with all the pressures that we got, there were 3 people who were outside of the county inappropriately, and 17 people who were outside of the county in PICU placements, psychiatric intensive care unit placements. So, and that was because during this time, our acute mental health wards were incredibly busy. So not only were we struggling with staffing, the wards were incredibly busy. So with 100% occupancy levels, I don't think it ever went below 97% occupancy from the 27th of December to the 14th of January. So for that 2.5 week period, we were incredibly busy. As soon as a bed became available, with somebody being available to be admitted into it. Next slide, please. So the staffing challenges within our organisation were equally felt with our colleagues across the mental health pathway. So adult care, domiciliary and care home workers similarly impacted. The ability of care homes to take admissions either because of outbreaks or because of staff absences was incredibly constrained during this period. But also supported accommodation providers as well. So you get a sense of that for that 5 or 6 week period, from the end of December through to the end of January, an incredibly pressured system where you were reliant on the flow of people through a hospital system into being cared for in community settings, all of that equally under pressure. Because of our ward staffing challenges, we did have to redeploy some of our staff from other services into the ward environment so that we could maintain safe staffing levels on the wards. Whilst we didn't have to close any other services, it did mean a reduced service in some of our community provision. But we didn't actually close any services during this time. Next slide, please. We set up, just as in previous waves, we re-established incident management team meeting on a daily basis to monitor and manage all the resources that we'd got on a day-to-day basis. We'd got business continuity plans in place across all of our services, which we instigated and worked through, and a daily drumbeat of regular meetings, looking at quality of services, looking at our staffing levels, looking at absence rates, looking what we needed to do in order to maintain services. So everything was under constant review. We set up a specific cell working within the incident management team to look at discharges. So because of the challenges within the care home environment, one of our normal routes for discharges was severely curtailed. So we had to look rapidly at other places in which we could safely discharge people. If it meant an expanded domiciliary package in someone's home using perhaps our crisis and home treatment service, we did. But there were also other facilities that we used and worked with and opened up in order to maintain the flow. We actually used, and I'll come back to this in a moment, used some additional winter monies that were made available to us from NHS England to expand our step-down facilities in some of our step-down beds that we were then able to make more use of. A general ramping up of the discharge work through the course of January resulted in us successfully dealing with the occupancy, the very high occupancy levels that I talked about a moment ago. And we've been able to continue that work through a less pressured environment and got our occupancy levels on the wards down to 85%, which is optimal. So we've been, the ways of working that we adopted during this period, we've been able to get real benefits from maintaining that through the course of the rest of the year. Next slide, please. The crisis helpline, the 24/7 mental health, LD and autism helpline, it's available for all ages to call. It's been operating since June 2020, so it's a well-established service now. It's continuing to see high levels of calls, an increase in the number of calls through December, which we were able to manage and work with. The bit of data here on the 3 months running up to January, so November, December, January, with some of the numbers involved. I think the thing that I would just want to emphasise is that a lot of people are able to get their needs met on the line, just from having someone to talk to, and where there is no need for any escalation, and it's dealt with through advice, guidance and support. And that's the vast majority of cases, but there are still a good number of people who are actually, via calling the helpline, are avoiding being admitted, because we're able to refer them into our crisis teams. Our crisis teams are then able to arrange to meet them either in their own home or in a place of safety. We've got the Safe Haven that's well established now in Derby and working really well with the helpline and our crisis teams. And we've seen a significant reduction in the number of people who are attending A&E because of the helpline service. 24 people were avoided, that the police had been in contact with. 24 people had their needs met without needing to be sent to A&E and conveyed by the police. That's saving police time. It's also saving time in A&E. It's also a better experience for the person who's in crisis. And we avoided 11 Section 136 detentions through the helpline, being in touch with the policemen and the police officers as they are working with the individuals. So that direct advice from a mental health professional to the police officer who's working with the individual at the time has actually avoided, in this 3-month period, avoided 11 detentions under Section 136. So we feel that the helpline and the wider crisis services we've now got in place are working really well, even at times of significant pressure, as they were this winter. So next slide, please. We were able to do some extra work this winter because of additional monies that we received from NHS England. We have been able to roll the use of that money over at the end of March into next year because we've been able to make longer use of the money over a longer period of time because some of these interventions are working. We updated our online wellbeing, emotional health and wellbeing website, which is available via both local authority websites. That's available to professionals working across the system, but also members of the public. We've got specific website for adults and also specific websites for children and young people as well to access. We have got the Safe Haven that's now been operating in Derby City for the last 15 months now. It's working really well. It takes people from across the city and the county. It's an alternative for an A&E attendance for somewhere safe for our crisis teams to work with somebody to try and avoid an admission under the section or an admission onto the wards, where they can be supported for a period of time and then hopefully back with support into their own homes. We employed some additional discharge coordinators on the wards, but also additional investment in social care staff and social workers to work on our wards over the winter to maintain that flow of people and maintain discharges through that period. We also commissioned 4 additional step-down beds from Rethink, again, to make sure that we'd got enough capacity to be able to discharge as quickly as we could, even at times of pressure. Coming up across the county, we're going to be we're calling them crisis cafes at the moment. We're trying to think of a better name, but essentially drop-in access facilities staffed by the voluntary sector in 3 permanent locations around the county. We've already got 1 in the city, 3 locations around the county with a mobile resource for the west of the county as well. So that will be coming up this year. This is about expanding further those opportunities for someone to, when they are struggling or in crisis, to get the support that they need and arrange a place where people feel comfortable, or where people can just drop in and get the support that they need from colleagues, and where statutory clinical services are available to respond if people aren't able to get their needs met from the voluntary sector. I think that was the end of the slides. I hope that's given you a picture both of how mental health services in particular responded to the pressures in the early part of this year, but also a bit of a picture about how services are developing when it comes to urgent care and mental health. But of course, I'll take any questions from the committee.
Councillor Hussain.
I wonder if you could comment on the level of service that you were able to continue with when services came under acute pressure because of staff absences or maybe greater level of referrals coming in. And obviously, you know, I assume you had to concentrate on people who were in most acute need. And some of the people who were slightly lower down may have missed out during those periods. I can say this without having an idea, without being able to picture who might have still carried on getting the service and who might have not got the service at that point in time. And secondly, if you could comment on whether or not services have now returned to near enough normality, because things seem to be getting back on track.
Yeah, thank you. One of the things that we've learned through the whole of the pandemic is that we need to keep all of our caseloads and the people who are waiting for our services under constant review in terms of their needs and potential risk. we've been able to stratify that risk across caseloads in the community. So what it meant when services became pressured and we had to redeploy people to support our wards, we were able to identify from within the caseloads people who might be able to wait a little bit longer for their regular follow-up appointment, enabling those staff to see people who are more urgently in need, or perhaps even to be redeployed. We've got people who need to be seen, perhaps have their medication reviewed on a regular basis, who perhaps aren't seen in their own home, but perhaps attend a clinic on a regular basis, who to be able to, perhaps it's not great to have an appointment cancelled, of course it isn't, but in terms of overall risk, it was less of a risk to them to perhaps wait another 4 or 5 weeks to have their regular appointment, to free up members of staff to be able to be seeing people who needed to be seen urgently. That's the sort of judgment that had to be made, and we're quite well practiced at it now after 2 years. In terms of services being re-established, yes. So the impact of the Omicron wave has been worked through. I think the ongoing challenge for us, and I think for all service providers, and I'm sure internally within the City Council as well, is going to be sickness absence. So if we've got a level of endemic COVID within the community, it means you've got more people off sick more of the time. You've got more people, if their children are off sick at school, they need to be at home caring for them. You know, if you're having to isolate, you're having to care for a family member, you're not necessarily able to work. Now, some of that is mitigated by our ability to be able to work from home and work more flexibly than we did in the past. So there is a return to some normality, but some things are different. So I think we certainly have a higher level of sickness absence than we did before the pandemic, and a wider absence from the workplace. Having said that, we are now in a place where we are getting very close to us being able to open up our facilities, not quite as normal, but certainly to see more people face to face than we've been able to see people over the last 2 years. We are making moves to bring people back into the workplace, not full time, but certainly as part of a hybrid model of working. And we're certainly looking at the balance of our space, our estate, to get the balance right between the clinical space that we're able to offer, of which we want more, and the office space, perhaps, that we don't need quite so much of anymore. So we are starting to implement the lessons that we've learned through the pandemic, and I think that will be the other thing that will be different in terms of how services are provided on a day-to-day basis. But it feels that certainly we're starting to return more towards normality.
Councillor Martin.
Thank you, Chair. Yeah, I just thank you for that. It's very interesting. Just there are lots of things I could ask about the time during the critical stage of the pandemic. Let's hope that's behind us and not ahead of us. And also many other, other points we could make. I mean, the issue of discharge is something from hospital. Is something that this committee has been concerned from really since the beginning of last year, when we advised not to close the London Road Community Hospital rehabilitation wards. And so, if you forgive me, current chair, I would just reiterate that point in this meeting, because the care homes can't make up for that as was planned. But on specifically your report, thank you. I do really welcome the crisis phone line. Is the Derby and Derbyshire mental health phone line is what you're referring to? Yeah. So thank you. So just a couple of observations on that, because I won't go into enormous detail, but I've set up a little bit of a project since I've been elected in my own ward that I represent, Darley Ward, where we've got a small group of residents together and we're trying to promote awareness. We can't help people with mental health problems directly, but what we're trying to do is promote awareness of this. So that helpline is one of the ones we've been putting on posters that we put around the ward. We have had professional approval for our posters, don't worry. But so that's really good, and so I would just ask that you also consider promoting yourselves more. These, I mean, there is a series of helplines. Some of them are directed at, say, men only, which, as we all know, is absolutely important for vital for people on the verge of suicide, because we know that the suicide rates among men are, horrific, men particularly. So there's lots of good things out there, but if you could find ways of promoting your own a bit more, I think that is something that's really important, because I know it's not a very catchy title, I must say, for the line, unlike some of the voluntary ones, which are really good and are very memorable and go straight to the target group. So that's one issue. But just getting it out there, because I know that it ties in so well with with these services that you can offer following up from your, as we are the NHS, then there's obviously a great backup which some of the voluntary ones don't have. So basically, could you promote it more? And the other point is, is there any chance of having, we've talked about trying to get a kind of occasional drop-in crisis cafe type thing in one area of Darley ward. I'm sure there are many other wards, Arboretum, and possibly even Littleover, where this sort of thing might be helped. So can you tell us what chances we have of having some of that in our areas, please?
I'll go backwards if I can remember through the course of your comments, Councillor. Thank you. There will be an opportunity for the whole of the voluntary sector and groups to be able to perhaps express an interest in hosting some of the crisis facilities that we're talking about. So that will be made available. The CCG will be doing that. Now, a lot of that may depend on the size of what the offer is, and perhaps a network of small ward level facilities might be something that we could look at. I think we're open to ideas. I think it's fair to say. On the helpline, the helpline was set up in a real rush back in April 2020. I think we set it up in 4 weeks flat, right at the height of the lockdown and the first lockdown. So yeah, in terms of the title, it's not been branded terribly well, but it does what it says on the tin. But so it's a very practical name. I think I take that on board completely. That perhaps we could do with some branding and have a look at what might be attractive for people, whilst still being clear that what its purpose is. So yeah, I'll certainly take that away. We do quite a lot of work on publicising it. Again, part of it's not the catchiest number. So we are trying to think about how we can get publicity out there for using the helpline as much as we possibly can. So yeah, thank you for the comments. I'll certainly take those back. Just on your first point about what I think was a comment about the physical health rehab pathway, just so that if anyone's listening from Radio Derby to the tape or on that's not what we do. That was a different piece of work. I just don't want anyone to get confused around the London Road changes and the mental health pathway, because otherwise something might have legs. But yeah, certainly, thank you.
Councillor Grimmer.
Thank you, Chair. First of all, thank you very much indeed for your presentation. I was very surprised at the number of calls that went to the crisis helpline. It seems quite a vast number of calls, and then, as you say, it went up by 8% in December itself. Since January the 14th, would you say that things have gone back a little bit, or is it on a similar par, or has the situation become worse?
I think it stayed about the same, which is a good thing, because I think the more people who are getting the support via the helpline, the better, because I think we get some good outcomes, and I think that the increased number of calls was more related to the increased numbers of staff that we'd actually got and the increased capacity we'd got in the service to be able to take those calls, particularly overnight, rather than an increase in demand. There was certainly an awful lot of increase in demand for services during that period, but I think the number of calls and the number of people that we were able to connect to was because we'd actually got more staff available at different hours to be able to take those calls.
So have you got the same amount of staff now?
Yes.
You have.
So those opening hours that we had, the opening is 24/7, but the number of people that we'd got working to take the calls has remained the same since that period. Yeah.
So since January the 14th, have things improved generally?
It's number of calls, it's about the same. So we saw that increase from November to December, and then it's been about the same since then. And the same number of staff able to take the calls. It's a partnership between P3, which is a voluntary sector provider, and Derbyshire Healthcare's clinical staff. So it works really, really well. The peer supporters and advisors take the calls, and then if somebody needs a clinical view, then it'll come through to clinicians who are in the centre. They're now working from facilities in Ripley, rather than where they were before in Chesterfield. It's really starting to come together as a service, and because it's in Ripley, they're now able to respond much better to people who are in crisis and need the call, physically need someone to go out from the triage service, from the helpline service. They're able to do that better from the new base, which they've been in since July.
Okay, so my questions. It sounds like you're under a great deal of pressure. Are you looking after your staff? How are you looking after them? They sound like, it does sound, that from the other side, you need to be caring for these people and yourselves who are under all this pressure, because we don't want that illness trend that you are seeing to get worse because of their mental health.
No, it's been a real focus of us as an organisation, but also the wider Derbyshire health and care system throughout the whole period of the pandemic. We've got a staff health and wellbeing hub with a whole range of services, from advice and guidance through to counselling and expert interventions and psychology support. I think it's the 6 tiers of different services that are available to people, but dependent on the need, and that's available to all health and care organisations in the county, in the city. So we've worked together across the system with funding from NHS England to be able to support that. We do everything we can for Derbyshire Healthcare to try and support people on a day-to-day basis. One of our strategic objectives was to put people first, knowing that by focusing on our own employees' and colleagues' health and well-being, that's more likely to result in better outcomes for the people that we serve. So in terms of even before the pandemic, the health and well-being of our colleagues was one of our prime organising principles. So yeah, it's very much at the forefront of our minds.
Excellent. That's very reassuring to hear, because it can be neglected, even in a scenario such as yours. The 4 extra beds you mentioned, are they still in action?
Yes, yeah. So the step-down beds that we've commissioned using the winter monies, they're still in operation, certainly to the end of March, and I think for a period of time into April and May. We are currently reviewing the number of step-down beds that we need, partly because of the short-term nature of that winter funding coming to an end, but also because we're getting our flow better and we're getting our length of stay and our occupancy down on our acute wards. we're able to have a better idea about what additional facilities we need in the community in order to get that optimal, really, to get that right. So yeah, at the moment we've got 11 beds closed due to COVID, space, environmental reasons. When we're able to open those beds, if we're able to open those beds, it may be that we can make different decisions about the number of beds that we've got available across the whole of the system. So I talked about the beds that we've got in Castle Donington from a private provider with those continuity of care arrangements. They are there specifically to make up for the beds that we didn't have available due to COVID in Derby.
Okay. Well, that's all my questions. Do we have any other questions? Okay, I am going to... Well, thank you very much for your report. It was very extensive. And we would like to note this report. Yeah. And yeah, just thank you very much for coming. That's really good. Thank you very much.
Thanks for having me. And also, if you have got any, if the committee or any other committee members who haven't been able to be here tonight have got any further questions, we'll be delighted to answer them in writing or via email through the officer. Okay. Thank you.
We'll certainly be, I will certainly be in touch about what we can get down at ward level if there's anything, please. That's a very interesting offer. Thank you very much.
So our next item is item 6, provision for people with chronic conditions such as Emmy, chronic fatigue syndrome and long COVID. If you would like to make your presentation.
I think that's myself. So I'm Dr. Steve Lloyd. I'm the Executive Medical Director of the Derby and Derbyshire CCG. So good evening, Chair, Councillors and colleagues. I'm just going to talk just briefly about what people understand as long COVID or post-COVID syndrome. And just bear in mind that obviously, as we're all aware, that COVID-19 is completely new to humanity, basically. SARS-CoV-2, as we know, erupted onto the global scene, goodness, 2 years ago now, and it really does seem like 2 decades. But the science is new around this in terms of what are the outcomes of SARS-CoV-2 infection, and there's a lot of unknowns still in this area. So in general terms, what people colloquially know as long COVID or post-COVID syndrome, there's a definition of this which is most helpful that's been circulated by Nhs, and that's enduring COVID-19 symptoms over 12 weeks, though some would argue that actually over 8 weeks is more valid. But nonetheless, Nhs has set the bar at over 12 weeks. And in general terms, this is a really disparate collection, potentially, of symptoms. And certainly Imperial College, in June of last year, in a small study they did, defined 2 main categories of long COVID or post-COVID syndrome. A smaller group, which was principally respiratory symptoms, such as enduring cough, enduring shortness of breath, and a much larger group with more generalized symptoms, and particularly fatigue. Other studies that have been more recent, such as the Zoe study, again identified 2 main groups, one being principally respiratory symptoms, alongside fatigue and headache, and another group which was more sort of almost organ specific in terms of its symptoms, particularly cardiac symptoms, enduring dizziness or palpitations and so on and so forth. But overall numbers, and we've got to think about, you know, a whole population basis. So the Office of National Statistics suggests that 3 to 12% of those who've had COVID still have enduring symptoms beyond 12 weeks. And And it's very difficult to sort of gauge the impacts at this stage of what the vaccination program has had, for example, on the long COVID prevalence and occurrence. But again, the ONS suggests in the UK some 1.3 million people have experienced or are experiencing long COVID symptoms, and that equates to some 1 in 50 of our population. And like I say, the impacts are quite difficult to gauge on this because it's such a wide and disparate variety of presentations. And again, what's the cut on this? A recent Leicestershire study suggested that the majority of hospitalised patients, some 70%, do not fully recover even at 5 months. So again, that's an aspect of long COVID that needs to be considered. And at this point in time, it's difficult to know how long COVID lasts in its various iterations. But there are reports emerging even now of patients experiencing over 12 months of symptomology. And like I say, this can be a very variable course, and it can even be cyclical in nature. And I've seen that in my own clinical practice where patients, for example, have had atypical chest pain, post-COVID, some element of respiratory symptoms, it settles down, they may acquire COVID again, particularly the Omicron variant, and it sets it off again on a cyclical basis. So like I say, there's a huge amount of unknowns within this. But cutting to the chase, the most common symptom post-COVID and enduring beyond that 12-week cut is fatigue, basically. Some 51% of patients do experience fatigue. And certainly with the first variants that we experienced, loss of sense of smell, anosmia was a significant feature in long COVID. And again, that's flagging up in some 37% of patients, alongside shortness of breath and all sorts of other difficulties, particularly in concentration, brain fog, and so on and so forth. And it's very difficult, like I say, to think how this is going to play out in the future and what level of service that we need. So if I just go on to the second slide, if I may, that just sets out really what I just want to talk through briefly this evening, and obviously we share this pack going forward. So what's been the response to post-COVID as a service response, let's say? So in the next slide, if you may, that really sets out what our response was. So back in October 20, NHS England very quickly launched a directive and some guidance alongside the NICE guidelines that were floated at that time about the definitions of long COVID and how we respond to it. The danger is that people experienced COVID in the community or in hospital settings and did not have access to what was quickly emerging as, for some people, a very enduring course of symptoms. So we very rapidly put in place, at the behest of NHS England, an assessment service. There was a requirement for a specific assessment service for patients, and certainly in Derbyshire we were very quick off the mark with this and got that in place for December 2020 to accept referrals from GPs and secondary care for patients who are beginning to experience these post-COVID syndrome symptoms. And further guidance came through in June 21 on actually configuring rehabilitation services for these cohorts of patients. And the lead provider throughout Derbyshire and from day one has been Derbyshire Community Health Services, DCHS, and specifically looking at a focus on patients with chronic fatigue, with shortness of breath, and some of the psychological impacts of long COVID that are particularly enduring and quite unpleasant. If you move on to the second slide, if you would, please. So like I say, the level of service that we put in place has been quite comprehensive and has been flagged up as in the Midlands region as a very good service for our patients and population. So like I say, the lead provider for both assessment and rehabilitation is DCHS, and we very quickly formed, between the CCG and the lead provider, a clinical operational group to think through how do we put in place pathways for referral for patients and the management pathways that fall out of it, and also obviously to configure that along the lines of what I've mentioned, what are the specific symptomologies that we need to tackle, and being mindful, as always, of course, of potential health inequalities issues alongside. Next slide, please. So this is a very busy slide, and I don't propose to go through it in detail, but it's there for information. But what is the access route, basically, for patients? So alongside what we've got in place locally, there is a national digital offer as well, Your COVID Management. But essentially, patients can access this service through both primary care routes and secondary care routes. Principally, this is done through primary care. Obviously, patients will report to their GPs, and I've seen no end of patients, because I'm a practicing GP, even a couple of sessions a week. We get patients coming up with very vague and very disturbing, in many ways, symptoms that endure. And as I've set out, really, the most common presentations are fatigue, respiratory, atypical chest pains that potentially come on a cyclical basis. And that example that I gave of a cyclical basis I did see in practice last week. But essentially, the GPs do an initial assessment against a template that we have in place for GPs that are available electronically. They refer them to the assessment centre, which is run by DCHS. They are assessed both by telephone, face-to-face if necessary, and on the basis of the template that's submitted by the GP, and that are then signposted to the appropriate rehabilitation services. And these rehab services, like I say, are geared towards specific symptom areas, including the psychological and mental health aspects of things. So, like I say, it's a very busy diagram, that, but essentially that maps out the patient journey through our services. And alongside that, obviously, it's not just the rehabilitation aspects, but if there are more significant symptoms, they can be referred directly, for example, to a cardiology specialist or to a respiratory specialist for further diagnostics and for further assessment. Next slide, please. And what I'd like to just show on this slide is what's the Derbyshire experience of this. As you're aware, obviously, we've got a population, both city and county, of over 1 million patients. And a total number of COVID cases is just over 290,000 to date. And you can see the split in terms of the city and county experience there. The referred number of post-COVID syndrome cases amounts to 1,370. That's the referred cases. Bear in mind, a lot of patients do not report symptoms because they don't feel it's impacting upon their personal lives, and I have come across that myself personally, where patients just endure the more minor level of symptoms. But the option there is for patients to report to their GPs, and there is an online offer that's been developed nationally, Your COVID Recovery, which they can access as well. Now, the majority of referrals tend to be in the late working age group, 45 to 65, and as you go down the age groups in terms of youth, the numbers are correspondingly less, and particularly in the under 18s. But that does not mean to say that long COVID does not present in younger age groups. And again, I do have personal experience of a 16-year-old who was particularly troubled with both physical and mental health aspects of enduring COVID symptoms beyond 12 weeks to a quite significant degree. And that's just an example of the variability of this and the unpredictability of COVID-19. Interestingly, the majority of patients that are referred tend to be women. Some 2 to 1 is the proportion. And I really don't know the reason for that. And like I say, there's some unknowns within this at this point in time. And over 50% of the referrals are from white British backgrounds. And that's significant, really, because the proportion it seems to be skewed. You know, if you look at it on a population level, you'd expect that to be higher from a white British perspective. But nonetheless, you know, the figures that we've gathered from referrals is quite interesting. And in terms of activity, the referral activity on a primary care network footprint, and I can assure colleagues that that in Derby City in particular, the PCNs are quite active in terms of their referral patterns and behaviours. And I'll just run through some slides quite quickly. Next slide, if you would, please, just to demonstrate some of the salient points on that. So that slide that you see in front of you there maps out the total number of referrals across the time frame. And as you can see, there was quite a big surge when we were dealing with the earlier variants, and now it's more flattened out to a more even rate. It's simply not known at this stage what the impact of Omicron will be. Bearing in mind, obviously, we've got a very comprehensive vaccination program as well, and what is known from the science is that the comprehensive vaccination cover will reduce the experience of post-COVID syndrome. As I say, you can see in front of you there the referrals by gender to date: female 900, male 470. Next slide, if you would, please. And again, this is quite a busy slide, this one, but essentially it shows the age range triangulated against time as well. But essentially what that message is like I've just said, the majority of referrals tend to be in the working age groups, the bulk of them being 45 to 54-year-olds. Now that will potentially change over time given both naturally acquired infection and vaccine-induced immunity. Next slide, if you would. And again, it's not easy to read this, but essentially that's the referrals by ethnicity. And on the next slide, if you would, that's the referral activity by PCN throughout both the city and the county. Now, Chesterfield looks an outlier on that in terms of its referral activity. Bear in mind, that is one of the biggest PCNs in the country. And if you tot up basically those referral figures from the 5 Derby City PCNs, they are relatively proportionate. Though I note the Oakdale Park PCN is a bit low in its referral rates. It's simply difficult to understand that, I have to say. And we've got to map that against potentially what's the vaccination coverage, what's the infection coverage, and so on and so forth, and the demographics of those individual PCNs. So I'll just pause there before I move on. Are there any questions that you want to ask, or do you want me to just carry on through it?
What is a PCN?
Primary care network.
Okay, thank you.
Yeah, that's a collection of general practices which come together as a network.
Should we move on and have
Yes, of
questions
course,
at the
yeah.
end? Yeah.
Yeah, the next few slides are quite brief because they really do tie into the service that's been put in place, the post-COVID mental health response. My colleague Gareth has touched on a lot of this in his presentation, but essentially for patients who are referred through the long COVID assessment service with specific mental health issues are transferred across and referred across to our IAP providers, the improved access for psychological therapy providers that cover both city and county. And of course, patients can also self-refer into that route as well. Next slide. This is specifically around pre-existing ME and chronic fatigue syndrome services. Now, in Derby City, our colleagues at UHDB have been commissioned from 2004 to provide comprehensive services, specialist rehab services and assessment services for patients with both ME and CFS, chronic fatigue syndrome. That's not just for Derby City, but covers quite a significant chunk of the county as well. There is a different arrangement in Chesterfield, linked to Sheffield, but south of Chesterfield, the majority of patients are referred by their GPs into the UHDB service. I know I do refer them myself to that service, and that has been extended since 2004, and that slide just demonstrates the continuing activity of that service, even through the COVID pandemic. That's been a comprehensive service that's assessed both face-to-face, by telephone, and has been continuing. And again, the link to the long COVID assessment service is there for patients with chronic fatigue. Next slide, if you would, please. I think the next slide just covers off the north, which we'll skip over. And there's another, and that is roughly it. So happy to pause at this point and take any questions. And I hope that gave a view really of what the service looks like. Now I'll just briefly describe what challenge we've got with the long COVID service at the moment, bearing in mind the impact that the Omicron wave has had, that my colleague Gareth flagged up as the impact on mental health services. The same holds true for the COVID assessment and rehabilitation services. The most significant challenge and risk that we face at the moment is the extent of the waiting lists, which are currently at 12 weeks. The national ambition is to get those down to 6 weeks, and we put in place a number of actions through our lead provider to get it down to that level in pretty short order. So challenging the lead provider to put resource into the assessment service and to the rehabilitation services, bolstered by CCG staff as well, to get those numbers down to 6 weeks. We've also looked again at the initial assessment, if we can pull across patients to segue them into the Your COVID Recovery platform, and actually, given the length of the waiting times, have they recovered basically? Do they actually need to be seen and assessed again? But also, what we are doing alongside NHS England is tracking the activity of that service on a fortnightly basis. And certainly the referral patterns have stabilised at this point in time. Certainly in the last 2-week reporting period, we had some 41 patients that were referred, 46 were assessed. We've still got 200 odd patients on that waiting list. And like I say, with the extra resource in place, I'm fairly confident that we'll get this down to at least that 6-week guidance that we've had from National to achieve. So pause there. Finally, I'll shut up.
Councillor Martin.
Thank you very much, Chair. Dr. Lloyd, thank you very much for the report. It isn't actually the report we asked for, thank you, but we were offered a report on long COVID earlier in the year, and we did specifically say that what we wanted to focus on was services for chronic fatigue syndrome and ME. And if I may, no disrespect for yourself, I think the fact that that has been completely submerged within a 20-minute discourse almost exclusively on the issues of long COVID, of which this committee is very concerned. We've had reports on COVID as a standing item in all of our meetings this year, and we are all concerned about the effects of long COVID. But I think it is quite telling that we are asking the NHS to address the serious issues that people have been suffering for decades now with CFS and ME, and that isn't the report we've actually had. So I don't know if there was some confusion along the way. But if you wouldn't mind turning your mic off, please, because it won't be possible to. So I haven't actually asked my question yet. So if you just wait for the question. So going on to that then, which is something we are concerned with. Of course, thank you. You know, I stress we are concerned about long COVID. But what we know is that this is not new, because chronic fatigue syndromes and Emmy is not a new problem. There are many crossovers with some of the symptoms with long COVID. That is as sort of unproven as yet. What is clear, though, is that people have had CFS and Emmy for a long time. And so going on to what you do say in your report about that, I would observe that one of the problems we have in the treatment of chronic fatigue is that it's still very much a treatment with managing the symptoms rather than actually addressing the causes. The physio, the CBT, etc., can be useful for some people, particularly those with joint problems, etc., or time management issues, etc. But usually, you know, I think this really kind of actually tends to ignore the fact that the NHS doesn't, certainly in terms of the treatments offered here, don't seem to address or try to cure the problem itself. And it's a kind of fairly superficial way of dealing with it. And often people do have CBT, and that is a very good service in Derby, I understand. But it really doesn't. It's really you know, you wouldn't treat cancer this way. You wouldn't treat other diseases this way in terms of time management and CBT therapy. So my question really, and I don't know if you can answer it with respect, because obviously you've been sent here to, or you've felt you need to talk about long COVID. But I wonder what the NHS, if the NHS believes that its current approach to CFS treatment and ME treatment is adequate, or is there any movement towards actually dealing with the actual illness itself rather than its symptoms? Thank you.
Thank you, Chair. Just a couple of observations. One, in terms of the presentations, the message we got was to present on long COVID as well as CFS. So I think there has been a communication failure on that. And I've been away off sick myself for a number of weeks, so the presentation tried to cover both. Now, in terms of the causes of chronic fatigue syndrome, as a clinician, the treatment options that are generated through that service are best practice. I have to say, the cause of chronic fatigue syndrome and ME are really have been controversial in the past, and it's very difficult to pin down the actual cause of CFS and ME as something you can treat specifically. So I would urge some caution in saying what we have got in terms of a service offer, can it be expanded? Because I think we're following very closely NICE guidelines in terms of management of said conditions. So I think that needs to be borne in mind, but certainly happy to expand that presentation at a future date to go through both the presentation of patients with those conditions, the management pathways, and the NICE guidance that supports the services that have been developed from 2004, if that's okay, Chair.
Yeah, is it okay if I come in here, Councillor Clement? There was new guidance recently issued for the treatment of ME and chronic fatigue syndrome. Has that been actioned within our setting?
I can't respond to that at this point in time. Like I say, I've been away, and I'd have to bring that back as a separate presentation if that's the requirement of this forum.
Okay. Councillor Grimond.
Thank you, Chair. I'd just like to make some general observations with the experts in the chamber itself. We don't see COVID on the TV as we used to, and I know that a large number of people think that it's going away. We've got the Omicron strain, and it's very hard to predict the future. But as an expert, would you say that new strains can easily appear, and then we've got to have more injections? And could new strains be more dangerous than previous strains, which would then put so much pressure on everything that you do? I mean, where is the situation with this?
Yeah, happy to answer that as both Executive Medical Director, Senior Responsible Officer of the vaccination programme and the LRF Science and Technology Advisory Cell Chair, which has now been stood down, of course. So, in terms of COVID-19, I refer to SAGE 105 when it was still stood up. There's been a strong advisory, which I completely concur with, is that certainly the next 2 years will be quite an unstable and unpredictable picture of what could happen with COVID-19. There's a high probability of a new variant emerging. And certainly within that time frame, I would suggest in the next 6 to 9 months, we may see a new variant emerge. Now, Omicron in itself is probably exceptional in terms of its mildness and in terms of its less severe characterization in terms of symptoms. Let's not forget in this country the comprehensive achievements of the vaccination programme, which has mitigated the effect of Omicron. And we're seeing now in the wider world, for example in the People's Republic of China, where they're experiencing Omicron BA2 variant, where they have not got the comprehensive cover, particularly in the elderly age groups, they're running into trouble in terms of hospital admissions and increasing mortality rates. Omicron variant has had this badge that it's somehow a very mild experience. Incorrect. If you have had a comprehensive vaccination, first dose, second dose and booster, it gives you a significant level of cover against the more severe aspects of Omicron, and particularly hospitalisation. But there is no guarantee of the outcome of that. And that's just Omicron. And that's thought to be quite exceptional in terms of its emergence. Another variant may well emerge, like I say, within the next 6 to 9 months, certainly in the unstable period of the next 2 years, which may be, one, more transmissible. It's got to be more transmissible because it's got to outcompete the Omicron variant. But in terms of severity of outcomes, it may well be more severe. And correct, we will need to continue, as the vaccination programme is continuing, in terms of vaccinating the population, and particularly the most vulnerable of our population going forward. Repeat boosters is strategically, this is at a higher level than my pay grade, is probably an expedient at this stage to try and mitigate the effects of COVID-19. The second generation vaccines that will be coming forward, hopefully we can push out to 12 monthly vaccinations for the whole population. But that is purely speculation at this point in time. But to summarise, there is a high probability of a new variant emerging in an indefinite period of time over the next 2 years. Beyond that 2-year period, COVID will probably become more seasonal in nature and become an autumn and winter experience in a similar fashion to influenza. But it's an unknown, I'm afraid, at this point in time.
Can I just, excuse me, just ask one more question? How long does the protection last when you've had the 3 jabs?
It depends. It's a good question and it's difficult to answer because It depends on the variant. So, for example, the Omicron variant, people with first and second doses required a booster of the Pfizer product to give an adequate level of protection against that variant. Now, for the immunosuppressed, like I say, the strategy at this point in time is to try and have a booster every 3 to 4 months. Now, that will change, obviously, depending on patient age group and individual vulnerabilities. So the next part of the vaccination strategy will be to get a booster going forward into the most vulnerable groups, the over 75s, and those at risk from COVID, particularly the immunosuppressed, as a first order of business in the next 6 months. Into the autumn, the thinking will be health and social care workers, care home residents, obviously in the former group, I should say, and potentially cohorts 1 to 9, as we've seen before in the autumn. Beyond that, unknown at this stage.
Councillor Martin.
Thank you, Chair. Thank you. So going back to the issue of chronic fatigue, Dr. Lloyd, given that, I mean, we can hope that the almost exclusive focus we've had on COVID in the last couple of years might actually have an effect on treatment for CFS and Emmy sufferers who do struggle to get any kind of focus on their condition. And sadly, you know, I do think, disappointingly, not your fault, I know, that this evening's report has done exactly the same thing that we have tried to avoid in asking for this report. So basically, we know that already in terms of CFS sufferers, it costs the economy, you know, up to £100 million a year in lost productivity. So imagine how that would be if people who suffered COVID add to that. But, you know, we must remember there are people who've got diseases that are not COVID and they're not necessarily caused by COVID. So, you know, with that in mind, I mean, I appreciate you may not be able to answer this tonight. I'm not sure what your area of, if it's responsibility is directly, but what, if you can answer this question, what do you think what is the recovery rate like for people with CFS following on the NHS treatment that they receive? Thank you.
I can't give you the detail at this point, I'm afraid, Councillor, because that area is not in my direct responsibility. As I suggested earlier, the ask for this evening, probably a bit of mixed messaging going on, and I'm more than happy to bring back a more focused item covering off chronic fatigue syndrome from both service delivery and outcomes based on the latest guidance.
Councillor Hussain.
In your presentation, I think you've said 1 in 5 people with learning disability is in receipt of help and support. But there's no comment on people with autism, whether anybody, you know, we've got 600 odd people who have been diagnosed as having autism. But there is no indication what percentage or what sort of numbers are actually in receipt of help and support from the local authority. I was wondering whether you could comment on that. And secondly, if you could comment on those people who have got autism, are they receiving appropriate services? Is there help available to them which is tailored towards meeting their needs? Or is that something which is still evolving or is not quite there yet?
I believe that's more relevant to the person who's doing the next thing. Do you want to answer that now, or do you want to hold that question and do it in your presentation? Is that okay, Councillor Hussain? Yeah. Are there any more questions on the report we've just received? Okay, so with noting the dissatisfaction that we got a report on something through communication area, through whatever, on a slightly different area that we want. It was a very interesting report. Thank you very much for delivering it. I would like to note it, and I would like to request that we get a report back again for the topic that we want to, which is chronic fatigue, ME, and chronic conditions, because we would like to hear more about the fact that even though we're in a crisis with other conditions, with COVID, that we're not neglecting that aspect of the NHS. Okay, you would like to?
Yeah, it's just, I think this is the second time I've come to this committee, and it's the second time there's been confusion about the subject matter of something that we've been presenting. So I just wondered whether the chair might want to consider checking with the CCG or from whoever's presenting that actually the subject matter is correct and we're attending to, because otherwise what we don't want to do is repeat frustration for you and for the committee. Was obviously we've responded with the presentations that came to us via the CCG, so I just wonder whether we need to check those messages before we get them.
Yes, thank you very much. I mean, I'm not aware of a previous occasion when we've had particular confusion, to be honest. There probably was one. We haven't had that generally throughout the year.
It was your first one as chair.
I don't remember. I don't remember that, to be honest. That's probably a hangover from the previous year. So I think generally the system works well, but obviously I totally appreciate there's been some confusion on this particular issue. I mean, it goes without saying that we are going to be very concerned about COVID. This board, whoever makes it up next year, because this is almost our last meeting, will be concerned about COVID. We will want reports on COVID, and we are concerned about people who suffer long COVID. I'm not aware that there's an endemic problem of confusion, if I'm honest. But what I will do, I mean, what we want, I'll say this now but as I say, I may not actually be the chair next year, but I would request that a report comes to the first meeting of next year, which sets out the numbers of people, the situation with chronic fatigue and ME, the numbers of people suffering from it, the nature of the treatment, and the outcome of the treatment on the NHS. So if we could have a report on those issues, please. Thank you for next time. But yeah, thanks a lot.
I concur.
Can you said next year, and it might confuse some participants because our year starts in June and not next year in January.
Yeah, I'm sure they're used to civic years, financial years, NHS years, and many other years. But yes, the next civic year, thank you, which will be in June. Thank you.
We are now moving on to item 8. I can't find my agenda on my computer screen. Yes, it's...
Thank you, Chair. Good evening, everyone. My name is James Lewis, and I'm Head of Joint Strategic Commissioning for Learning Disabilities and Autism, and I work for Derby and Derbyshire Clinical Commissioning Group, but I'm in a joint funded role with the 2 local authorities as well. And I've come today to give a broad update about learning disabilities and autism, and hopefully the nature of the report will reflect how we're working as a system, health, social care, community services, to improve the lives of people autistic people and those with a learning disability. So I'm going to start by just briefly going over learning disabilities and autism in Derby. But very briefly, so a learning disability defined by MENCAP is a reduced intellectual ability and difficulty with everyday activities which affects someone in their whole life. There are a variety of different causes, and these can occur prenatal, perinatal, and postnatal. But probably some of the most recognised is Down syndrome, and conveniently today it is World Down Syndrome Day, and cerebral palsy. But there are lesser known causes such as the result of infections such as meningitis or measles, or sociological environmental factors such as fetal alcohol syndrome or injury as a result of abuse. And learning disabilities should not be used interchangeably with learning difficulties. Learning difficulties include things such as dyspraxia and dyslexia. There are approximately, according to population estimates, 4,700 adults with a learning disability in Derby and about 1,500 children, and which represents about 2.2% and 2.5% of the adult and children population respectively. Separately, autism is defined by the National Autistic Society as a lifelong developmental disability which affects how people communicate and interact with the world. Autistic people often describe it as a different way of experiencing the world around them than others have. And because society is not designed around autistic people or neurodiverse people, this can cause challenges and face issues, which can include social communication and social interaction, repetitive and restrictive behaviour, over or under sensitivity to light, sound, taste or touch, extreme anxiety, which can sometimes be described as meltdowns or shutdowns. There are approximately 1,950 autistic adults in Derby and 600 children, and this is based upon a prevalence rate of about 1% of the population. Prevalence rates for autism is a really contentious topic. There's been a recent study from Newcastle, Cambridge and Maastricht University suggesting it could be as high as 1.57%, and there are studies coming out from America which suggest that it could be up to 3% of the population. So that would triple the population estimate, which will kind of give you an insight into some of the challenges that we're facing. Just kind of an overview, there are 891 working age adults with a learning disability in receipt of long-term support from Derby City Council, and this includes a broad range of services from home care, residential care, supported living and day services. The significant majority of adults with a learning disability, about 80%, live with families or on their own. 80% of autistic people experience mental health issues during their lifetime, the most common comorbidities being anxiety and depression, and furthermore, autistic people are around 9 times more likely to experience suicide ideation than the general public. The average age of death for men with a learning disability in Derby and Derbyshire is 60, and it's 62 for women. That's around 20 years younger than the general public. Autism is the most common primary support need for children and young people with an education, health and care plan. However, this likely doesn't capture all autistic children who may require support. Evidence suggests that autism is under-recognised in diagnosing girls, for example. And finally, only, and I'll say only, 22% of autistic adults are in any form of paid employment. Compare that to the unemployment rate of 6.3% in Derby. And only 2.8% of adults with a learning disability in receipt of long-term support or in any time of paid employment. Compared that to a national rate of 5.1% across the board. So just a bit of an overview on the types of health services available for autistic people with a learning disability. So there's community support through specialist community nursing, occupational and speech and language therapy. There's the mental health services like Gareth described. There's an intensive support team, which until recently was a specialist learning disability team, which coordinates and delivers care to prevent and address crisis. There's a forensic service, which provides specialist support for people who've been part of the criminal justice system. There's a range of inpatient services, including a learning disability assessment and treatment unit at Ash Green Hospital, as well as local mental health inpatient services, and at times the use of out-of-area hospitals. NHS provided respite services in the north of the county. Neurodiverse diagnostic services, so when I say neurodiverse, I mean things like ADHD as well. The main two providers being Derbyshire Healthcare Foundation Trust for Autism and Sheffield Adult Autism and Neurodevelopmental Services. That's in reference to adults. There's also children's diagnostic services as well. A strategic health facilitation team which provides guidance and support to GPs for example, in providing reasonable adjustments, and making sure people with a learning disability can attend their annual health checks and other primary care appointments. A programme team, which ensures that we deliver the requirements of the NHS long-term plan, including coordinating and supporting care and treatment reviews and other multi-agency meetings to support individuals' health and well-being, and psychology and psychiatry, including community psychiatric nursing and clinical psychiatry and psychology to support community and inpatient care. And next slide, please. So those services are fairly universal across Derby and Derbyshire, but I'll comment a bit more specifically about Derby City in this slide. So residential and nursing care services were commissioned by the council or available to self-funders, and there's currently 138 people whose primary support reads as a learning disability who's open to Derby City adult social care in residential care. Supported living, which offers the opportunity for people to have their own tenancy, often living alongside others with care and support provided by a commissioned provider. Shared lives, where people are matched with an approved carer to share their family and community life, as well as providing care and support. Some people move in with their shared lives carer, otherwise it includes regular visits, including overnight. Day services, where staff and volunteers provide activities for children, young people, adults and their families. For example, Manor Care Farm, which is the 35-acre site on the outskirts of the city, which provides people with the opportunities to develop animal husbandry in a safe and controlled manner. Therapeutic and wellbeing services such as Inspiritive Arts, which offers psychotherapy and wellbeing sessions run through drama, art, music or movement therapy. Learning and education, not just through specialist education settings, but also through universal services such as Derby Adult Learning Service. Advocacy, which helps people to express their views and wishes alongside standing up for their rights. So this includes statutory advocacy services, which helps people who are being assessed as part of a legal framework, like a Care Act review or a mental capacity assessment. And one advocacy is provided by Citizens Advice Mid Mercia. Parent and carer support, such as the Parent Carer Forums, which support parents and carers in providing their caring role. Parent Carers Together is Derby City's Parent Caring Forum, and alongside their support role, they contribute to our work to improve services. And information, advice and guidance on a range of topics from universal credit to where people can access care and support. This is provided by organisations such as Citizens of Mid Mercia and complements directories such as the Community Directory Derbyshire and the Local Offer. So that's a brief overview of the types of support that's available for people, autistic people and people with learning disability. So I'll go on to what our plans are. So in March last year, all integrated care systems were asked to develop a learning disability and autism roadmap, which had to outline how we were going to deliver the commitments of the NHS long-term plan alongside any of our local learning disability and autism transformation priorities. Stakeholders from across health, social, community care, including representatives from the voluntary community and social enterprise sector and autistic people and those with a learning disability, were given an opportunity to contribute to the roadmap, including our ambition statement to reconfigure how care and support is delivered for people and their families, and we want to move away from reactive and intensive interventions to preventative and flexible support in local communities. In doing that, we developed a simple framework, hopefully a simple framework by which we want to achieve our ambition statement. We think that if we can make improvements across the different parts of the pathway, such as crisis and inpatient care, ensuring the quality and availability of care and support services provided through education, the NHS and social care, and building strong and sustainable community assets, then we'll go a long way to achieving our ambition. And it should be noted that improving care and accommodation is a foundation across all of these different areas. The approval of the roadmap unlocked NHS England investment, which we're now using to transform services and deliver kind of our priorities. Next slide, please. So what do we want to be different by the end of the roadmap, by 2025? We want fewer people to be inpatients by investing in community-based alternatives to inpatient care and supporting discharge pathways and admission avoidance pathways. We want more people with a learning disability to have their annual health check by increasing the number of people registered with their local GPs and ensuring the quality of the health action plan, which is what you get after your annual health check. We want no one to have an inappropriate do not attempt cardiopulmonary resuscitation order in place when they pass away. I can comment a little bit more on that later if there's a specific question, because there often is. We want fewer people with learning disability to pass away with a recorded death of epilepsy or constipation. There's a very famous case of this nationally, which is part of the reason why there's more recognition of this area recently. We want an increase in the percentage of people who are in paid employment, which I kind of talked about earlier, but we want the public sector to be leads in that. We want to decrease the number of autistic people who complete or incomplete suicide by working alongside autistic people and their families and health, social and community care professionals to understand, recognise and prevent suicide ideation. We want communities and services to be more neurodiverse friendly by increasing awareness and understanding across all sections of society. And we want to decrease the waiting times for neurodiverse assessments as well. So what have we done to date? We've created a specialist autism team in the NHS, and the National Institute for Health and Care Excellence recommends that every system has a specialist autism team, which is a multidisciplinary service that is responsible for delivering, coordinating, delivering care and support. Our service launched in October with an initial focus on supporting people who are in crisis. We participated in the Oliver McGowan mandatory learning disability and autism training pilot, and staff from Chesterfield Royal Hospital, Derbyshire County Council and local advocacy services have now received autism awareness and support training whilst we wait for the rollout of the wider programme. We've had initial concepts for a new child and young person key worker role approved, and these were co-designed across the integrated care system with further work to refine the service and delivery model taking place from April. We've commissioned a new voluntary community social enterprise sector lead organisation with an additional focus will be improving autism post-diagnostic support. In addition, a new community of practice has been established which brings together the VCSE from across Derby and Derbyshire to support self-improvements and address any gaps in services. We've begun the harmonisation of the two community NHS trusts by the creation of a single leadership structure and work to develop a single clinical model between Derbyshire Healthcare Foundation Trust and Derbyshire Community Services Trusts. We've improved the neurodiverse diagnostic pathway for children, young people and parents by implementing a new parental e-learning, the launch of a new digital autism portal and commissioned additional diagnostic assessments. We've increased the number of people who've had their annual health check despite disruptions because of COVID-19 and the vaccination effort. We've overseen an increased number of discharges from mental health inpatient settings through strengthened partnership working, developing new community services like more view supported living in Derby City and additional investments in clinical posts. And we've mobilised an integrated team to oversee operational improvements, and that's really started to take effect from December this year. Our future priorities on the next slide, please. We want to further improve the neurodiverse diagnostic pathway. We know that we need to reduce waiting times, as well as ensuring appropriate support available before, during and after assessment. Further potential innovations in the future include creating an all-age pathway and bringing together the various neurodiverse diagnostic pathways, autism, ADHD, gender dysphoria, and integrating different services into the process, such as housing and employment. Develop new care and accommodation, such as including new specialist LD and autism step-down services, which can improve opportunities unavailable for some people who were inpatients in the past. We want to improve accessibility and the quality of mental health services. We know that good community-based mental health support is critical to improving health and well-being for autistic people in particular. That's why we're heavily involved in the community mental health transformation and mental health in schools transformation programs. We want to align operational pathways across health and social care, ensuring an integrated approach, promoting good outcomes, personalisation and value for money. We want to create neurodiverse-friendly communities, learning the lessons from dementia-friendly communities. And I wanted to stress that this isn't about having neurodiverse-friendly sections of society. This is about having one which is truly inclusive all the time. We want to invest and enable our voluntary community and social enterprise sector through our new approach. And if it works, we want to be able to invest further in the future. And lastly, we want to ensure people's voices are heard by embedding a consistent approach to engagement, co-production and co-designs. And I'm really pleased that NHS England have recognised our achievements in this, but we want to do more. We want to make it a real hallmark of our local effort. So last slide, how we're all working together. So there is a integrated care system governance through a system delivery board, which includes a learning disability and autism steering group with various roadmap work streams and support structures such as finance and a soon-to-be-launched workforce group. And the board includes representation from health, social care and the VCSE. The delivery of the programme accountability is transferred from the clinical commissioning group to Derbyshire Healthcare Foundation Trust to provide new ideas and resources to the programme, as well as forging closer relationships between strategic and operational colleagues. We're integrating learning disability and autism resources and assets from across the integrated care system to make best use of what we've already got. This includes aligning work programmes and a more transparent approach to system finance. We're working closely with colleagues from children and young people and mental health services to improve specialist and universal services offer. And lastly, again, re-emphasise engaging with autistic people and those with learning disability and their families. Some of these forums have continued throughout COVID-19, such as the Derby and Derbyshire Autism Partnership Board, whilst others, such as the Derby City Learning Disability Partnership Board, has just been restarted and had their first hybrid meeting a couple of weeks ago. And I've included on the last slide just a link of some resources to them, some of the services that I've talked about. Thank you very much. Happy for questions. I hope that's given a broad overview of what is a quite broad and complex agenda.
Thank you very much. That was very interesting. Councillor Hussain, since you asked the question, how's it been answered?
Do you want me to repeat my question, or did you write that down?
No, I've written them down.
You might as well start answering.
It's nice that my presentation was so exciting that you jumped to it. So, yeah. So, one of the issues that we face is that when I was talking about prevalence of autism, is that it's not just myself, we don't record autism as well as we could do in a number of different ways, whether that's in employment and including who's receiving social care support and health support. So actually commenting on the number of people who are autistic who are receiving support from social care or health is more difficult than it is for people with learning disability. That's why it's not presented as an infographic on the slides that I put forward. However, I can tell you that the second question was how appropriate is support for autistic people. The answer to that is it's really varied. There are lots of autistic people who live their whole lives without access to any services at all. There are lots of autistic people who get really good support, and there are lots of autistic people who raise really challenging questions to us about the appropriateness of the support that they get, and whether people recognise their autism as being the primary cause of the concerns that they've got, or whether it's something else, whether it's mental health, etc. So it's a real mixed bag. I think this is one of the things we're primarily trying to improve. And I think one of the ways we're going to do that is the work that I was talking about in terms of the voluntary community and social enterprise sector. I think we're really proud that we've put in place a system where we can invest in that area. And throughout COVID-19, they've demonstrated how agile and how dynamic they can be in supporting autistic people, moving from hybrid to virtual to face-to-face. And often people just want to be recognised, but often people just want to have space to talk to someone, feel connected to people, or if it's neurodiverse diagnostic services, want to recognise greater identity in themselves and recognise, why they experience the world differently than other people. That's what we're trying to improve. So it is a mixed picture, I have to say, but one that we're really hoping to improve over the next few years.
Councillor Martin.
Thank you. That was a very detailed report. Thank you. I just have a few kind of reflections. I've got three, I think. So if I just say them all, and then if you could come back on them rather than as a question and answer thing. First of all, you interestingly, you said that girls tend to be underdiagnosed. With, I think you mentioned that almost as an aside, actually, which is an I mean, this isn't something you can give an extensive response to this evening, because it's a huge question about the way autism is defined, because it is certainly true that just anecdotally, a lot of autistic traits, as such as they are commonly understood, tend to be attributed to kind of masculine behaviour traits. So, you know, it's just that whole point about the way autism is defined. I'm not as, I suppose my question is, just say a few points on that without giving us an exhaustive thesis, because I know there is no definitive answer, but I just wondered if you wanted to just elaborate slightly on that. Thank you. The other thing would be that you talked about the move to community care, and I mean, I suppose if you could just say, I know you gave a lot of detail in your report, but if you could just say a little bit about what that means concretely as such, because I don't think that you're anything like in this domain, but we know that some years ago care for psychiatric patients was moved into the community, and, you know, frankly, I mean, some decades ago, it just wasn't adequate, and I'm sure that isn't what's planned. And recently, in this council, we had a move away from daycare centres into personalised budgets, and then there had to be a shift back from that to a bit of refocusing on the provision of daycare centres, because people still needed to pay for daycare centres with their personalised budgets because they needed a daycare centre. So if you could just give, again, you can't possibly do it exhaustively, a few points about what it is you mean, what are you aiming for, what would that actually mean concretely. And the final point was just that there are, I try and get to grips with all these different services and help support networks myself, and it is quite it is overwhelming. So I can see that could be a very positive thing, because there's lots of different organisations trying to help lots of different people, but is there a single point of contact, and if there isn't, would that be useful? Thank you.
So thesis number one. Autism diagnosis in girls. You're absolutely right. You know, I tried to do a fair amount of research into what people are saying, and a lot of people say that the diagnostic test for autism was primarily tested on boys and men, and that's why we've got a legacy. The second thing that the board members might be aware of is something called masking behaviour, where or kind of chameleon-like behaviours, where they copy behaviours of other, where autistic girls might copy behaviours of other people, whether that's a fitting in process, whether that's you know, how they exercise their life choices. So it means that they sometimes mask their traits in the and it doesn't get recognised then. I think that there is a lot of work going to be done on the neurodiverse diagnostic process, from particularly in education is a really important step, recognising in schools where children spend a lot of their time, and children spend a lot of their time potentially interacting with other people as well. And we are wanting to invest heavily into making sure that there's recognition of all the different symptoms or the signs and characteristics of autism early on. And I know that there is focus work going on in partners across the Midlands looking at this as well. So I think there is another locality in the Midlands that are doing a specific piece of work on focusing on girls in schools and how we can improve the mental health and autism support available for them as well. Lastly, on that kind of thing, like I said, the diagnostic picture is very complicated across the whole country, and it doesn't feel like a local solution is going to be enough to this. It feels like a regional and national solution is what's going to be required. And increasingly, we are talking to our commissioning and strategic colleagues in Leicester, Leicestershire and Rutland, and Coventry and Warwickshire, and Nottingham and Nottinghamshire about how we can work together to improve all of this. So it's an area of real development that's needed. More studies come out weekly from different areas as well. So getting to grips with what is a complicated landscape is really quite difficult. But thank you for raising the question, because it's probably an area that in what was hopefully a comprehensive summary kind of maybe got a little bit lost. So thank you for raising it. In terms of the move towards community-based care, I think there's a few levels to this. I think that we all recognise that the best place for people to receive long-term care and support is not in mental health inpatient settings. It is in local communities. It is with local support networks. There are real challenges in delivering that. I think the most prominent one of those is a workforce, which you may have heard in other board reports, and Gareth was talking about the effect a workforce had on the COVID-19 recovery and response. It's felt as acutely in learning disabilities and autism, and there is a level of specialist care that you need to be able to give to make sure that people who might have even 2 or 3 years ago demonstrated behaviours which would mean admission to a mental health hospital can actually stay in their community instead. So there is work that needs to be done, and investment on that front for what is a small percentage of our learning disability and autism population. Beyond that, I think one of the things that comes out to us significantly is that people don't necessarily want loads of support. They want a bit of support when they want it. And that solution feels like it can be best, most flexibly delivered in local communities through the voluntary community sector, who can, at times, demonstrate more agility than the public sector can do. So, for example, in the new VCSE work that we're trying to deliver, we want to explore the idea of no discharge. So services are open to people for however long they want, and they might come one day a year. That day may be associated with a personal trauma, or it's that time of year that they feel like they want more support. But that challenges us as an integrated care system. It succeeds some of our responsibility over to the VCSE in a way that we might not have done previously. But it's one that we're really quite excited about. And you know, like I said, the way that the voluntary community sector work with people is really inspiring. The last question was about having lots of different organisations and a single point of access and knowing where people want to go. So there are services like the ones I described that provide information, advice and guidance to people, and we need to make sure that those services are publicised, like you've commented on the crisis helpline, make sure people know that those services are there for people. I think the other thing that we really want to do is we want to improve the referral links and the pathways between diagnostic services and those types of services as well. So when you get a diagnosis, and this is really important, particularly for autistic people, you are not handed off to a information, advice and guidance service. You are supported to access an information, advice and guidance service, including however much you want to intensely, you want to go with the person to the first appointment, or you want to sit in with them on a virtual appointment, so that then they know where they might be able to get the different types of support that they want. I think lastly, we want to focus over the next 6 months in particular on mapping out all those different VCSE services that we've got available, and making sure that firstly there aren't any obvious gaps, but secondly everybody is aware of what everybody else is doing, so we can get it right first time where people might go for their support that they need. I hope that's answered your questions in a not too long and meandering way.
Councillor Zane.
Can I just make a very quick comment? I think part of the difficulty is the way these things are actually implemented, because the government under pressure from stakeholders, mainly parents, carers, etc. Take, for instance, autism. they will make it a mandatory service for local authorities to provide. But the problem is nobody does an assessment that if we assess people who've got needs related to autism, we will have, say, in the country, 60,000 people. That's the rough estimate on the government part. And nobody works out what new finances need to be put into that service to make it workable. What they do is, under pressure, they will make it a statutory duty for local authorities or health services to say, you go out there and assess and provide. But it's not usually accompanied by any additional finance. So the service providers then scratch around and they pinch bits and bobs from here and there, and they try to provide some sort of response. It's not just autism, but there are many other services which have been introduced in the last 25, 30 years in that particular way. And then from the provider's point of view, because there's no additional finance attached to it, so in terms of finding people who've got those needs and then having a response for those identified needs, they're put in a bind. They've got a bit of a vested interest, actually, in many cases, to perhaps overlook and not, because they know they've got limitations in terms of finance to be able to respond to those identified needs. And I think we perhaps need to make a recommendation, although it's not going to go anywhere, but that it needs to be given better thought. And any additional needs identified, any new conditions identified, when it's made a statutory duty for either our health partners or local authorities, should accompany additional finance.
That sounds sensible to me. So, what?
Just ask Farid if he's going to state what the recommendation.
Yeah, do you want to state a recommendation? Do you want to state a recommendation? What we should recommend? So recommendation that yeah. Okay.
And you okay? Yeah.
Okay, so we should recommend that as the assessment of neurodiversity increases, that there should be a financial increase in relation to that. Is that basically what you said, Farid?
Suggestion would be when new conditions are, new service areas are identified, then the government should more accurately estimate the additional cost to the providers, local authorities or health partners. And before the government makes a statutory duty on health or local authority, they should make that financial assessment, and they should accompany a financial package to come along with the new statutory duties.
I'm quite happy to second that thing.
Yeah. I think that's unanimous, seconded, and yeah, everyone is pro that as a recommendation. So we'll send that as a recommendation if that's, hopefully that's helpful. I do have one question. Say one of these people who has been missed in childhood as being autistic, is high functioning autistic spectrum and is able to mask and manage, decides, right, I want to find out why I find life so difficult, and goes to their GP and says, can I go for an assessment? How long is the time frame between going to that initial appointment to getting diagnosed and that, oh, that's why?
So the waiting times for autism diagnosis for adults is currently just over 3 years. Patients do have another option rather than a CCG commissioned diagnosis through something called Right to Choose, which is they can access a different service. However, there has been a significant rise in the demand through Right to Choose and private providers, which meant that even as recently as kind of like 6 months ago, the waiting list for those providers is now over a year long as well. So it's not as if there is a ready solution to this. There is going to be a really focused piece of work on addressing this element of the pathway. I would have thought that Scrutiny would be interested in this in the future, particularly considering the number of people that this could affect, and the overall package that people need to receive around a diagnosis as well. So what do they get pre-diagnosis? What do they get after diagnosis? I suppose my last comment that I would make is that if there's loads of integrated care systems across the country, each of them might be doing something slightly different on this. I don't think anyone's put their hand up and said we've absolutely cracked. We haven't really cracked this diagnostic pathway. That doesn't mean that we're not going to put a huge amount of energy into it. What it means is that the answer is not readily obvious. But part of the solution is 100% going to be working alongside clinicians, and part of it is going to be working alongside autistic people as well, because they're going to have to be a key partner in this, so that we can understand what makes a good diagnostic process for them, we'll be led by some of the work that's going on in children and young people's at the moment as well. The long-term solution to the problem is in children and young people's. If you get it right in children and young people's, then you're limited here. But we do need to address the adult waiting times, absolutely.
Yeah, I would agree. Are there any more questions? Do you want to turn your microphone off? Are there any more questions? Okay. Well, thank you very much for your report. Thank you, all of you, for your reports. That has been really interesting. I am now going to hand the chair back over to Councillor Martin. Thank you very much, Councillor Martin.
Thank you, Councillor Lonsdale, and thank you for 3 really interesting reports tonight, and special thanks to Dr. Lloyd, who gave an excellent report, but unfortunately wasn't the one I wanted to hear. So thank you for that. It was an extremely important report, and we look forward to hearing a further report in the new civic year on Emmy and CFS, but all really, really important issues. I know that these issues that you've spoken about tonight are really close to the hearts of some of the people in this room. So we will take away what you've said, we'll reflect on it. Maybe we'd like to invite you to talk again, and we'll check the wording that before the invitation goes out. But because we really do value the work you do in these areas, and thank you very much. Thank you. So very quickly then, we're moving on I'll just mention the work programme and the topic review. So that was, thank you, yeah. So that was about some of the prospective work programme next year. We do have our meeting on the 19th of April, which is mainly going to be focused on dentistry services. We have somebody from HealthWatch coming to talk about dentistry. We do have one other report as well, but that will mainly be dentistry on the 19th of April. On the topic review, we've got a few interviews left to do, and then we'll be sort of winding that up, and I guess Lindsay and I will mainly be putting a report together. So thank you very much for everybody who's been along to our sessions. It's been so interesting, but we're not quite finished yet. We do have a date for a potential visit to the West End Community Centre, as came out of one of our topic review interviews, and that's I think that was the 31st, wasn't it, Lindsay? So hopefully members will be able to come along to that. So if there are no questions on those items, on that, no, I'll just note that we did have a report on the update on the older people's mental health services consultation. So because we have a lot of items, we've just left that to note. Does anybody want to raise any points about that at this stage? No? Brilliant. Thank you very much. So that just leaves us to meet again on the 19th of April. Thank you, Lindsay, for her support tonight. Thank you. Good night.